Okay, welcome everyone. It's 5 o'clock and we're going to get started because we have in the next hour. I'm pleased to welcome you all to today's seminar on social prescribing, hosted by the Center for Research in Health Systems Performance, or CRiHSP for short. My name is Laurie Goldsmith, and I'm a Senior Research Fellow in CRiHSP in the Division of Family Medicine at NUS. So today's policy dialogue will consist of two speakers. The first speaker brings an international perspective, and the second speaker is bringing a local perspective. They will be followed by a brief commentary by two panelists, and then we'll have an opportunity for the audience to ask questions. But before I introduce our first speaker, I want to take a moment to define, sorry, my screen's not moving. Before I take a moment, I want to take a moment to define social prescribing. So social prescribing is a process that was first introduced in the United Kingdom, and it's a process to connect individuals to non-clinical services and activities. It's characterized by deliberateness, by individualization, and by being person-centered and person-driven. So now on to our first speaker. Our first speaker is Professor Nicholas Goodwin. Professor Goodwin is director of the Central Coast Research Institute, a joint venture between the University of Newcastle and Central Coast Local Health District in New South Wales, Australia, that acts as a research and innovation center to design, develop, and embed new models of care into policy and practice. Professor Goodwin has worked for the past 30 years across the university and third sector, acting as consultant on integrated care policy and practice across more than 25 countries worldwide, including for the World Health Organization. He was founder and first CEO of the International Foundation for Integrated Care, and in 2016 received the Avitas Donabedian International Award for his contribution to healthcare excellence. So clearly we're in safe hands with Professor Goodwin taking us through the international evidence behind social prescribing and sharing lessons for successful implementation. Professor Goodwin. Nick, you're muted.
Muted, sorry. Thank you very much, Laurie, for that kind introduction. It's very good to be here in Singapore and to be involved in CRiHSP's initiative here, looking at social prescribing. So my role is to look at what the international tells us, both about impact and implementation. But we'll start with a bit of recognition that social prescribing is and continues to be a global initiative. As our global population ages, the burden of chronic disease grows. The health and social care sectors have considered additional alternative approaches to how we can support better population health management, how we can improve care and delivery and health outcomes for people, particularly people who are living as community dwelling older adults or people living within the home environment. So implementation is growing globally. So you see the chart on the right, the map of the world there with the red countries highlighted. This was a piece of work undertaken by colleagues who provided the definition that Laurie just mentioned about social prescribing. And these are countries that have advanced social prescribing schemes. So many of them in Europe and North America, but also you see growth in the Asia Pacific region as well. And if you go beyond that mapping of 14 countries to other sources of information, you see there's a growth in Central Europe. You see a growth also in India, Malaysia, Taiwan, and of course in Singapore. So I guess I'm going to give you the summary of what I'm going to say, and then I'm going to say it, and then I'll conclude with what I've said, which is what someone told me once was a good way to present. So the aim and approaches to social prescribing, these vary significantly. So when you look to different parts of the world, there does not appear to be a single approach that seems to be adopted. Although some countries like Wales or the UK try to have a national framework of what it looks like and how it should be done. Other countries provide a more laissez-faire approach, understanding the principles of trying to grow a community response to meet people's needs in addition to their medical issues, but are letting those approaches kind of develop naturally over time. So they vary significantly, both the aims and the definitions, but they reflect very similar healthcare, socioeconomic, cultural, and political contexts in which we're trying to make change. We also find that evaluations of social prescribing are mostly providing positive outcomes, and we'll come on to that, but more research is needed in order to be able to understand outcomes better, particularly in terms of impact on service utilization and costs. And actually understanding how best to position social prescribing in specific health and social care systems is lacking. So in a sense, we know there are positive benefits here, but we don't quite know where they come from, or indeed where social prescribing should best sit. And what I think is suggested in the literature and many of the recent evidence reviews is the need for more international collaboration to promote knowledge and best practice about social prescribing so that we can learn from each other to understand what works. Social prescribing, I think, also comes part of a longer term trend in many other areas. My area has been integrated care for many years, where we seek to coordinate care and services around people's needs in primary community care settings through multidisciplinary action. But it's also related to things like population health management, person-centered care, where we try to meet individuals' needs and preferences, including chronic disease management. It also fits in with the increasing approaches we have for people-driven care, where we're looking to co-design and co-produce with people as partners in care in order to be able to get people in the community very much with the agency to be able to design and deliver the care around them. It links into all of the sorts of health coaching, supported self-care, self-determination approaches, which tries to enable people to become active in what influences their health and make the right choices, give them the motivation to change and draw on people's strengths to do so. And if we take a more community social care perspective, there are issues like assets-based community development and connected communities, where we're looking for the community to come together and almost self-mobilize the assets and resources around themselves in order to make a difference to people's lives. And lying at the heart of this, and in fact, lying at the heart of all of these, is a value-based care proposition. How do we improve the care experiences and care outcomes of people cost effectively and equitably and sustainably? And the idea of social prescribing, it contributes to an approach where we're seeking to create value in health and social care. So social prescribing can have many objectives. And as we go through, I'm going to create some policy boxes potentially for discussion at the end. It can seek to change people's health behaviors. It can nudge people in terms of their diet or exercise or smoking or substance misuse, or it can be very targeted to specific disease management questions and supported self-care, deep mental health and counselling. So health behaviors is one. Another one is related to social emotional issues. So many people may not be living with particular diseases or particular health issues, but they might be socially isolated. They might be having difficult circumstances, and they might need to feel as though they want to be more engaged in the community in which they live. So engagement, volunteering, getting jobs, getting access to green spaces, nature, music, art. A lot of the issues to do with social prescribing also focus on those social, emotional, mental health and well-being issues. Sometimes about meeting material needs. So I'm working out of Australia, but in New Zealand, we know that a lot of the social prescribing for the Maori community, particularly urban Maori community, focuses on how do we address things like food and transport and financial issues and housing and digital inclusion, all the things that support families to be able to survive and live healthy and well, including the care support that fits around them. And yet another set of objectives thinks like, well, social prescribing, this can be approached to make a more sustainable health system for ourselves. It might lead to prevention of hospitalization or reduced length of stay, reduced medication use on the healthcare side, maybe delays in transition to residential care on the social care side or the aged care side. So the first policy question should be, should we seek to have a core set of objectives or outcomes prescribed in social prescribing? Should we try to look at this list and find a way and say, well, social prescribing should really focus on these priority areas? Or do we leave it to contextually kind of, or local decision making as to what really matters for people? But because there are a range of different types of approaches and focus on what social prescribing should do, it's not surprising, therefore, that we see a whole range of different outcomes that are attributed to social prescribing schemes. And indeed, when you look through the evidence and you look at issues related to physiological clinical issues, you see on the left there in the graph, or life impact or delivery of care or resource use, you see a highly variable, many different types of instruments measuring different elements of care and outcomes. Most of these are patient-reported outcome measures or experience measures. but other approaches are used as well. Perhaps less emphasis in the measures looking at physical function, cognition, and impact on caregivers and equity. Most of it looking on self-reported quality of life and ability to manage and people's own feelings of their health and well-being. The second policy question, and is there an approach that we want to use in Singapore, want to use in our particular location, and therefore should we have a standard set of outcomes, standard set of measures and tools that we'd want to use? And then when we look around the world, and I've just come up with some of the diagrams that different countries are using within their policy documents. So England, on the left-hand side there, uses a social prescribing link worker model. So it uses, normally funded through GPs or centrally funded, you place these link workers into primary care clinics, and GPs within those clinics refer to the link workers, and it's up to the link workers to then refer on or to find alternative support within that community. And usually the link workers are funded in England through joint health and social care commissioning. So the social care side and healthcare side coming together to pool budgets, and they fund the link worker model from that, but very much working through general practice. In Wales, just to the left, as we go in England, go into Wales, they move away from a GP-led model. It's more of a community-based prevention pathway is what they're thinking about. And referrals can come from many different sources, come from the third sector, come from community service, it can include self-referrals from friends and neighbours or people themselves. And generally it's targeted at certain populations, and in this case, usually the older people living with frailty. It's looking at the issue of aging well and supporting people live aging well and in place. If you go to Portugal and Spain, we're still in Europe here, both of them have very similar approaches, very different countries, but similar approaches, where after referral from primary care, in addition to signposting to different services, they support a degree of motivational interviewing, most often done by social workers. And that motivational interviewing really focuses on what the goals of care of a person might be, what might motivate them to make the changes in their health-seeking behaviours, and then through the planning that's done through that process to refer them onto a range of community resources that might fit with their own mindsets and thinking. If we come again to other parts of the world, like Canada, where they've had social prescribing for a while, they have a real diverse approach to social prescribing across their 13 provinces and territories. So there's no one model here, but they do have a multi-sectoral national hub seeking to develop a national framework. So we're seeing all of this activity. How do we make sense of that? So they're bringing together a hub that focuses in on the different models. And when we look into most of the models in Canada, a lot of them, like the Welsh, focusing in on how do we support building resilience amongst seniors, amongst older people and their carers, with the emphasis on supporting people to live independently well. So the diagram there is from social prescribing for people aged over 55 in Edmonton. And then we'll come on to a discussion of Singapore, but Singapore's been implementing social prescribing since at least 2019. And screening is done for patients with socially determined health issues. So we're trying to focus in on those patients where a social prescription or ability to support them with other forms of community intervention is going to influence their health and well-being outcomes, which is a really quite interesting approach. Singapore was one of the first countries after COVID as well to initiate e-social prescribing as well, which is a very interesting initiative. So the conclusion you come to when you start looking across the world is that most countries do not have a national system for social prescribing, but they have a number of regional approaches or pilot programs, and the health policy approaches in some countries sort of standardize the model, in other countries not. But where they're standardizing the model, it's largely because they want to focus on how do we fund it, how do we implement it, how do we assure quality, how do we support competence training for staff roles, and especially those link workers. So they're beginning to think through how do we embed a social prescribing model within the services that we provide. In Australia, I'm leading a program called ALICE. That's all-inclusive care for older people. We have a different approach again. So older people on the Central Coast are living in social isolation. They would say they're screamingly lonely. They don't know where to go for information and advice, and the health system is rather too fragmented for them to get the care that they require. So there is a two-point approach here. So one, for all older people living in a community, will provide them with access through community engagement officers to information around the services they might be supported by within their local community. And then for those who are in receipt of an aged care package, so those who are both have a number of long-term conditions, but also have frailty and require support within the home, we're focusing on a link worker approach to provide them with a single source of relational continuity that allows them to focus on what motivates them as an older person or their carer, but also look at finding about how we can draw down from our community assets to help. So another type of approach again. What is the impact of social prescribing? Lots of different models. So just going to flag up a few evidence from recent systematic reviews. So the Costa et al. Study looked at the effectiveness of social prescribing in a primary healthcare context. And not unusually, they found a number of different focuses for the research that they uncovered within their review. They got 13 studies they downloaded. So 10 of those looked at physical and psychological well-being, and 8 of those 10 studies demonstrated a positive impact. Just 2 of the studies looked at mental health and depression and looked at quality of life and measures of self-efficacy. Both of those showed improvements. But for those studies that were trying to look at positive changes, such as social connectors and social isolation, only 1 of those studies demonstrated a positive impact. Research by Griffiths of primary care in the UK, again, finding a broad range of social prescribing approaches and activities, but all of these demonstrated improvements in self-reported well-being status, or in terms of quality of life, or levels of physical ability or ability to self-care, connectedness to community. So across these 8 studies that they downloaded, very different approaches, different outcomes that we're looking at, but generally a positive experience. But the reviewers would point to weak methodologies, the difficulty to attribute the actual social prescribing to the impact that they were seeing, was partly because of the range of different social prescribing activities that they saw. Significant work from Pesheni and colleagues who come up with a number of different publications. This was their impact one, looking at service users from referrals based in primary care to healthcare navigators. And this is a very popular approach. And in fact, we at the Research Institute in Australia are doing an evidence review of the impact of care navigators based in general practice. So potentially this will almost be certainly included in that study. But what we're seeing is of the 16 cases that they came up with, 6 of those 16 demonstrated improvements in patient-reported experience measures for mental and physical health issues, linked to direct measures that they would have of blood pressure or weight loss or sugar levels before and after the intervention. There was consistently across the studies reported positive health and well-being impacts for general health and well-being. But if you focused on assessment on a specific indicator like anxiety or depression or medication use, it tended not to show change. Health-related behaviors like diet and exercise or self-efficacy or the ability to have confidence and greater agency in your care consistently improved in self-reports. Again, mixed results for social interaction and addressing social isolation. And as with previous reviews, really different study designs, relatively low quality, diversity in aims, and so on. And a final one, just demonstrating that diversity. This was a different one, which was looking at individual well-being, connectedness, and social isolation, partly because of the range of studies here. They came with 51 studies. They looked at this, and the diagram on the right sees how they're all connected to each other. So some are well-being studies and so on. But the evidence for positive change for individuals is generally robust. People feel positive about social prescribing and its ability to connect them to community. But most approaches generally focused on the health system rather than wider community resources. But again, heterogeneous studies, wide range of measures, difficult to determine causal influence, variable quality, lack of control groups. So they came up with recommendations in their review to improve program design, so how and why we should design programs, what should be expected out of them, and also program delivery. So what guidelines do we have that would move social prescribing from pilot programs into business as usual? So that's some of the evidence, so very varied, but if generally positive. And then when you come to implementing social prescribing, clearly there's no one model here, but the evidence would point to a set of guiding principles. So for people requiring social prescribing. We're trying to address the wider determinants of their health beyond medical. We're looking to develop trusted relationships with people, shared expectations and knowledge and co-creation and community building. We're trying to build trust so that people can engage more, not only in their own health, but in the health of their community as well. The skills of the link work are really very important here. Their relational continuity that they have to require with people. They're the coach, they're the negotiator, they're the coordinator, they're the advocate. They also have to work between health and the person and in between health and social care. So the skills of the link work are really coming through as a very important principle of things. The other one I think I'm very keen on, and when you look at person-centered care generally, you still find that it's a bit passive in terms of engaging people in their own health. So what I'm suggesting is that the evidence is telling you there needs to be an active enzyme to give people agency over their own care through participation or self-reliance or motivation or behavior. People have to take control. So getting that active enzyme in social prescribing to support people to do that more effectively, I think is important. And then perhaps, as usual, the enabling environment. So what do we do at a policy level or through regulation governance? How we pay people, the financial flows, the organizations and the teams? How do we create an enabling environment in health or in health and social care to enable social prescribing to happen? And we're not short of tools and guidance. So most recommend an implementation process than a set model. Such a process resembling the sort of approach you might take to health systems strengthening or strategic commissioning in how you plan and purchase health services, where you go through this diagnosis of the problem to planning the issue to implementing the monitoring and evaluation, and the importance of building social capital along the way. So having a guiding coalition at the beginning of your key partners, building support for change across your community colleagues, developing that collaborative capacity so can people to work together in a different way. So what do we have on the right there? We've got the WHO toolkit that I know members probably on this call have contributed to. Making sense of social prescribing, I think that comes from the UK, and the social prescribing training roadmap at the top is Canadian. So very similar. So lots of roadmaps out there you can download and find out how to do things. But the policy question here is, should there be a standard model in how we develop and implement social prescribing? So in conclusion, some key issues for policy adoption, some questions that emerge from this. What are the priority aims and objectives for social prescribing, and how can we therefore measure impact, and how should we evaluate it? Should it focus on priority populations and neighbourhoods? If so, how can they choose these? What do we do? Is there a preferred model for care that we want to have standardised, e.g. link workers working out of primary care? Or should we let 1,000 flowers bloom? Should we see a range of different approaches and see what works in different contexts? What about the workforce implications, particularly for the link workers in terms of their education and training, where they fit in terms of the system itself? Maybe we should take the health technology route. So how far should we go through e-social prescribing and the use of new apps and tools? What would the governance and accountability for social prescribing look like, particularly when it's embedded within communities and a whole range of different partners? And therefore, you're looking at alliances and networks. How do we govern and make accountable these services to make sure that they are the right quality and deliver the right outcomes? And lastly, what are the most effective approaches to fund and incentivize social prescribing? How do we do that? Is it through different forms of funding, or what do we do to ensure that social prescribing moves forward? So there is a quick tour of some international examples of social prescribing, some of what the evidence says, and maybe some key challenges and questions for ourselves who are interested in taking social prescribing forward. So with that, you can contact me here. I'm sure that the slides will be shared. So we've got some evidence reviews here and a few other resources and tools that you can download. So please look at those when you get the chance. So with that, I'll hand back to you, Laurie. And I'll stop sharing. It's Laurie, your turn to be muted.
Oh, there we go. Now I can unmute myself. I briefly couldn't unmute myself. So while I'm handing it over to the next speaker to pull up his slides, let me say two things. So first of all, apologies that I disappeared off the screen. I think it was something to do with my virtual background, which I've now turned off. And also, we're going to hold questions until the end after the commentary. There's been some commentary by our additional panelists. So please put your question and answers in the question and answer part of the chat. I know I see that there's some hands up. If you could put your questions in the Q&A, we'll take them from the Q&A. So with that, we'll go to our second speaker. Our second speaker is Dr. Linus Chua. Dr. Chua is the medical lead for the National University Health System, or NUHS, community care team, a nurse-led multidisciplinary service which works together with community partners to anchor care in the community. He supports various NUHS community care programs, including the interdisciplinary group initiative and integration of care between GPs and NUHS specialists. He practices as a family physician at Bukit Batok Polyclinic, and Dr. Chua will share on NUHS's efforts to facilitate social prescribing in primary care. Dr. Chua, over to you.
Hi, good afternoon, everyone. Thank you to the organizers for inviting me to share about the local perspective. And I'm going to share about our NUHS primary care experience so far in terms of social prescribing. So this is a diagram that's taken from the WHO toolkit. And as Professor Nick has shared, it involves a primary healthcare provider referring to a link worker, and then that link worker then referring to the relevant services in the community sector, and then with a closed loop follow-up, as well as feedback back to the link worker and ideally back to the primary healthcare provider. So what are some of the examples of the link workers that we have in our local context? I just broke it up into two columns. One is from a healthcare institution point of view. We have our medical social workers who we like to refer patients to. Any social issues, we like to refer to the medical social worker as almost like a cure-all. There are also typically care coordinators, or well-being coordinators, or care connectors running a similar role, but being called different names. We would have community nurses who work either in a home care setting, a transitional care setting, or within a community health post. We have allied health professionals, as well as typically we'll have call centers that patients can call up and ask for assistance. Now, from a community point of view, there's a lot of activity happening as well. There are many community social workers that practice within family service centers, active aging centers, and other social service agencies. We have community case management services, which I will come to in a while. And we have got grassroots staff, volunteers. We have got staff from the Agency for Integrated Care, volunteers that go door knocking from the Silver Generation Office, as well as care hotlines that the AIC has actually set up. And we have got community mental health teams. Now, what I really like about this is that there's a no wrong door approach. So typically, the link workers would be able to link to various services. And if those services are not able to provide the relevant help for the need, they are actually able to refer on to another service. And Singapore is a very small place. The ability to get to the required service that you need is actually very high. Okay, now back to social prescribing. I like to think about it as a family physician in terms of community activities that one could refer to, as well as community care support. So community activities that we discuss with our patients in the clinics, it would include things like, participating in an exercise group. And then we might refer the patient to look at the app where either under Sports SG or Healthy 365, you would see a screenshot on the right-hand side where the Healthy 365 app has collated a whole set of community exercise activities, and you could search based on your location, where you stay or where you like to participate in the activity. Then we have the active aging centers, which is the one-stop service. I'll come to it in a while. There are also community center activities, the local resident network. There are interest groups in the community. There are associations, plan associations. One could look up Skills Future to learn a new skill, to learn a new ability. And Singaporeans, we love traveling. So now that COVID has kind of restrictions have opened up, we could refer them to go for travel and group tours. Some are based on interest groups. And there are lots of volunteering activities as well. And I hear that the latest, most exciting activity is that of pickleball to keep active. Now, just to give an example of the wide range of services available at the Active Aging Center, this is a sample calendar, okay, from one of the Active Aging Centers. You would typically find a range of activities that include exercises, interests, groups, hobbies. There would be some aesthetic activities to join, like music, okay, or art. There would be group social activities like birthday parties, and there would be a health component, okay, something like a health talk, a dietitian, nutrition talk as well. So there's really quite a wide range of activities. And if we were to refer to one service for activities, a good service would be that of the Active Aging Center. I do have to say that is the current inclusion would be seniors that are above the age of 60 years old. Now come to community care support. Singapore has also done a good job in providing a whole range of supports for our residents. The first thing I would have to mention is a Community Case Management Service, CCMS, that actually helps to coordinate various help services for patients. And typically, they're able to provide or coordinate medication packing support, medical escort and transport for appointments, home help services, home personal care for grooming, showering of patients, meals delivery to the vulnerable patients. And if you look at the top right-hand corner of the screen, each location in Singapore is covered by a service provider for this CCMS service. Okay, and they are funded by the government for that. Now, I won't go through the various range of services that I've listed here, but on the bottom right-hand corner of the screen, you will see this QR code that is actually called Support Go Where. Is a care service recommender that is created by Agency for Integrated Care. And what you would be brought to is actually a page where you could key in a few questions, a few answers on basically what is the condition of your loved one. And then this service would be able to recommend, what are the available services that are for you. It's very comprehensive. Okay, so in NUHS, we do run a community care team, okay, and this is really run by nurses and supported by doctors and allied health professionals. Typically, we are able to do home visits, run community health post visits, and do phone call follow-ups with patients. And we have regular multidisciplinary meetings to discuss the care needs of the patients and make sure that they're well cared for. And we take referrals both from NUHS institutions as a step down, or from the community when we are escalated cases up to us. We're able to go in and do the assessment and really make sure that the residents' needs are well taken care of. Just a shout out for another group that has been running at least for the last 3 years. Okay, it's called the Interdisciplinary Group. This is more a community-based inter-agency case conference, and it's really set up to discuss complex patients. It's attended by GPs, social service agencies, a whole list of social services, medical social workers from the hospital, as well as our community care team nurses. And it started as a collaboration between Ng Teng Fong Hospital and the Bukit Batok Township, and now we are planning to actually scale it up to the rest of the NUHS cluster in phases. Now, we find that this platform that meets every 2 months is a very useful platform, not just to discuss the individual cases and make sure that their needs are met, but it's also useful for networking among the partners. And they are able to share the resources that they have available, and they are able to help each other understand what are the available resources so that we can understand the assets available in the community. As primary care partnerships, we look to enable our GPs in terms of social prescribing. So these are the ways that we have enabled our GPs to be able to do social prescribing. First cut will be the primary care network care coordinator. Secondly, we have actually curated based on the localities, key services and activities that are available that the GPs can recommend to their patients. Then we have the centralized services, which are the NUHS Care and Call Center, the NUHS Community Care Team, interdisciplinary group, and if the GPs are able to refer directly to the services available, they are able to do so as well. So this is just some data that the primary care network has in terms of the being referred to do social prescribing, and actually in just about 15 months, we haven't really had quite a lot of referrals. Okay, and we're hoping that this number actually goes up as CRiHSP stabilizes. From polyclinic perspective, social prescribing is largely done through the discussions that the care coordinators have with the patients during their CRiHSP consults. And if they are willing to be referred to an active aging center, the care coordinators will let the doctors know, and we will make 2 clicks on the health plan, and back end, the resident will be referred to the nearest AAC that's nearest to the patient. And now for community service referrals, the doctors would refer typically to a medical social worker or a financial counselor to be able to meet the needs. Just some experience from the ground that we hear from the other primary care networks. We hear that some primary care network HQs are partnering with individual social service agencies for streamlined referrals. We understand that the uptake of social prescribing generally remains low across the board, across all the PCNs. We do hear from GPs that the patients express a reluctance to visit the active aging centers, even though they have been referred. And many GPs are not engaging in social prescribing yet due to the existing CRiHSP teething administrative issues and administrative fatigue. So some thoughts that I thought will bring up for discussion also through my experience as a family physician is that does social prescribing really have to be initiated by a doctor? Can it be done just purely in the community? What role do inpatient hospital teams have in terms of social prescribing, given that the patients are there just for the acute phase of the illness? Is AI the future of social prescribing? Is social prescribing really the best way to provide self-activation, given that the word prescribing seems to invoke a sense of, I'm telling you what to do. Would it be better if the patients themselves were to get to the resources, and would that be better for the compliance to the activities? And the last question is, how do we actually meaningfully measure the effectiveness of social prescribing interventions if lifestyle factors are so multifactorial? So just a shout out, I think this was one of the links that Professor Nick actually put in. There is a Singapore community of practice in social prescribing, and if you're interested, do check out the website and you can register and be filled in with various social prescribing events and field trips. And there's the upcoming social prescribing conference. So if you have signed up, I'll see you there at the conference as well. Thank you.
Thank you very much, Dr. Chua. So now we're going to turn to our 2 panelists to provide commentary, but just a reminder to use the Q&A function if you have a question. Our first panelist is Associate Professor Jason Yap. He's the Vice Dean Practice at the Sa Swee Hock School of Public Health at the National University of Singapore. So, Dr. Yap.
Thanks, Laurie. I have 5 minutes, and I am basically a public health physician, so I'll be basically looking at sort of, in a sense, from a distance and from the macro perspective. People who know me know that I'm always interested in the etymology of words. How did this phrase social prescribing come about? I tried to search, but my conjecture is that when patients are in hospitals and they can't go home, we say they are social overstayers, right? And so when perhaps it was useful, even though social prescription is more than just society or something that's social or relational in nature. We go into exercise and other things. We say social as in the sense of not medical, and that's how it all started. And in a sense, if you are listening to the presentation, especially for those out of Singapore, we actually have a very medical perspective of social prescription, in the sense that it is not medical. But if you listen to Nick's first few slides, if you just look at it, we will realize that actually social prescription is a much larger concept than just what's non-medical, or just what the doctor does not usually do. So there's a big difference over there. If you look at the Healthier SG white paper, there's actually pretty little mention of social prescription as a role, and most of us actually, and you can see from, in a sense, indirectly from Linus's presentation, that the concept is largely of Linus even asked the question, should GPs be the ones to do it? I mean, meaning that they're the ones to do it right now. But if you look at Nick's presentation, from in other countries like Spain and Portugal, they go far beyond. And in the case of Alice in Australia, it doesn't start anywhere near healthcare. It comes from the other direction altogether. So arguably, social prescription is actually best placed under the Ministry of Social and Family Development, not the Ministry of Health. But that's not the way things have been set up over here. So the other question I have over social prescription, based on the presentation, is exactly what do we mean by it? Because as a national policy, we can say we want it, but to implement it, we require programs. But the phrase social prescribing also includes the actual act of prescribing. So in Singapore now, the question is it done by a GP or it should be done by another person? In the UK, they talk about link workers, and there's a very clear reference there. They actually hired people, trained them to be link workers, whereas we are using other kinds of stuff to function as link workers. So there is no job as a link worker. There's just the role or the function of one. So I think this is something that we ought to think through. Yeah. And the last part about it is that I think referring off to Linus's presentation, I think Singapore's done a pretty good job at allocating resources and setting up processes for social prescription, which Linus has gone through. I would just suggest that for the last item of what he wants to look at, beyond the effectiveness of social prescription, I think we should think a little bit also about the coverage of social prescribing. Because the key metric here is not just do people benefit from social prescription, right? Or but rather the other part about it is what's the base population of people who need social prescription, who are actually getting it? Because it's well and good to do very well for some people based on the processes they're in, but we have to make sure that everybody else also gets the services. And it's the coverage that's important for this if you are going to look at things from a population management perspective. Thank you.
Thank you very much, Dr. Yap. The second panelist is Professor Jose Maria Valderas. He's the director of CRiHSP and the chair of the Department of Family Medicine at NUHS and NUS. Over to you, Professor Valderas.
Thank you very much, Laurie. Thanks very much to the presenters and to Jason for his previous comments. I'll be brief because I'm aware of the time and I see plenty of questions piling up. So just 3 points from me. One is that I think that the concept, it touches on something that Jason has mentioned before. I mean, what's the notion of social prescribing, and if he was referring to the etymology. Well, I think that sometimes because things are presented within a health or healthcare framework, they may, for many people, lose appeal. So if someone might benefit from actually going to the gym or interacting with other peoples in their community, I mean, the very fact that this comes from a nudge or from a health professional because this is good for your health, paradoxically may to a degree backfire. So I think we need to be a bit cautious with this notion that because we doctors say so and advise it, that this will necessarily be welcome by patients. The second one is that is also a word of caution in terms of what are the implications of wider adoption of health social prescribing, which is basically that we're shifting responsibility from delivery of care within the healthcare sector to other sectors, which is good, but okay, that we also need to take some responsibility or need to make sure that someone takes responsibility for the quality of those services. So all the efforts that we make will be absolutely limited by the effectiveness of ultimately what the other services deliver. And that brings us to the third point, which is that I think that social prescribing actually is a prime example of how you can operationalize primary healthcare, the WHO approach to health systems, in which you need to ensure cross sectorial action, in this case, health in all policies, patient engagement, and you need a focus on primary care. So, if anything, this would suggest that systems that are endorsing social prescribing seem to be keen to implicitly endorsing the WHO principles of primary healthcare, and I think it's a very welcome development.
Thank you. Professor Goodwin, would you like to respond to any of the comments before we turn to Linus and then the question period? You have to unmute yourself.
I think I take the point about, I mean, I think there's a question around participation, how you get people to participate in that, and should it be through a doctor, or should it be other means? So I think there was the first question on that came in the question and answer. So maybe if I focus briefly on that, is I think there's something really important about in social prescribing about social engagement and how you engage. And I think it's culturally different depending which country you go to. So in some countries, the family physician, the family doctor, has a significant role to play in building the community infrastructure and the community feeling of engagement that you would have. We've lost that in many parts of the world as a result of a whole range of different changes. And there is some evidence when you look into some of the link worker research that we've been looking at to show that if you have a peer link worker or a community link worker, they rather get a better rate of participation, better levels of trust with them, as opposed to, say, a social worker or a medic or someone with a nursing degree. And I think that's partly a them and us situation. It's partly having someone supporting you who's like them, who can explain it to you in the right sort of way. There's something there about the way that we engage that potentially someone in a white coat in a medical facility might not be the right person. But it's the nature of that engagement. It's that social interaction, I think, between the person who is the link worker and the participation of the community itself is probably key to the levels of participation and response that you might get. And that's not just about, so it's not just about the other one is this tension. I think, you do social prescribing and suddenly you've got to get through 60 referrals to someone within your community who's going to provide a social response, because we need people to go to that over 50 centre to take on short mat bowls or whatever it is. That's what my over 50 centres does, or mahjong or whatever it is, eating club, leisure club. They might not do it. So I think you have to try to socialise the process as much as possible, so it becomes less of a referral and more of a conversation, so that people feel as though that they're becoming active in themselves. I can describe it like that. So for me, it's all about agency. It's about social interaction and agency, and I think that's the key to making social prescribing work. If it becomes too medical in an approach to prescribing and referring, then I think it might still have benefits, but it might not be quite as effective. But again, I think there's a cultural context around that, so you have to work it through and do your research on it.
Thank you. Dr. Chua, do you want to respond to anything that Dr. Yap or Professor Valderas said?
Yeah, I just want to catch on to what Dr. Yap has mentioned about the coverage. And I do see that in our Singapore context, in the HDB blocks, there are seniors who are living alone, and really the question is, how do we get to them? How do we get to them proactively, and how do we get to them before things happen? And really, I just see that the social services and the local neighborhood communities would potentially be able to get to them much more effectively than any of the healthcare workers. So we do have to work together.
Thank you. So I'm now going to turn to the questions in the question and answer panel. I don't think we'll be able to get through all of them, but what I'll do is I'll try to move them around to make sure we've got a mix. So the first question came in during Professor Goodwin's talk, so I think it's directed at him, but certainly Dr. Chua, if you want to add anything more. So what programs have shown good patient participation, and what were key elements for this, and were there any ethnic differences? Professor Goodwin.
That was for me.
Yeah.
Yeah, well, I think I partly just answered that. I think what we're seeing is that if you've got the opportunity to do social prescribing, you mustn't miss the opportunity to understand what motivates people. So the better outcomes, it seems to me, are those where when you have the link worker going to work with the person, or indeed their family member or carer, there's an opportunity to do maybe a goals-based assessment or something so you can understand what is going to motivate that person in their own context. And then your role is to do two things. Some of it is also to be the coach in order to be able to support people and nudge them in the right direction in terms of the behaviors they might take forward. And the next role that they have is to ensure that connection based upon what's going to motivate the person. By tailoring that approach, both in terms of the coaching and the referral to something the person is really going to get engaged in, I think is going to make a difference. And I think there is a little bit of evidence that that might be the case. And I think the other one I think is I've mentioned before. It's ensuring that the social relationship is strong. The relational continuity between that link worker and the community is strong. And sometimes if you're a busy medic or a busy social worker, where there might be a little bit of stigma attached to that association, might not work. In other cultural contexts, it might. So we just have to work that through, who might be the best group of people. And I think Linus showed it could be a whole bunch of different people, but we don't necessarily know. Would they all work? Possibly, quite possibly, but we don't quite know. But that's worth an investigation, because we need to know the role and function of link workers. And I think we kind of know them, but maybe not to the fullest degree.
And any information about ethnicity in the data you're familiar with, Professor Goodwin?
Yes, so there is a definite equity issue that Jason came up with in terms of coverage. So I think there's definitely an ethnicity issue. And as ever with things like social prescribing or integrated care or anything else, you've got an inverse care law, and it's often the people who would most benefit from social prescribing who lose out. Because they're living in rural and remote communities, difficult circumstances, hard to reach group. They've got mental health issues, multiple comorbidities. These are much more difficult to engage in a social prescribing entity than people who maybe already have ready activation that just needs to be sparked a little bit. So that's worth having a look at to see whether social prescribing is really who's it really going to be for? Because I think if we're thinking it's going to be for the people who are really quite in significant need, to help them remain within the home or community dwelling with the needs that they have. Well, for a lot of people, I think social prescribing may pass them by, or may not even reach them. So I think that is a key issue, and then ethnicity will definitely be a part of that.
Thank you. Dr. Chua, do you want to add anything from the NUHS perspective? Then I'm going to turn to Professor Valderas and then back to the Q&A.
Yeah, just a quick comment about the ethnicity. I've come across various examples of social prescribing that has been effective. For example, if it has come through certain either religious communities or even the traditional Chinese medicine practitioner community or clinic, and I think that those really represent groups that will never turn up at our Western medicine clinics. Yeah, so just want to put that in.
Thank you. Prof. Elderis, would you like to say something?
Yes, very briefly, just to say that, I mean, when we're asking about what sort of patients, what sort of initiatives, I mean, how the interventions are shaped, I think that social prescribing is a very complex intervention. There are at least 4 things that need to be considered: the population, the health system, the services in the community, and not least how all these things are put together in the form of specific interventions. So even evidence from a beautifully designed randomized controlled trial in the country next door will give you little information about how you should develop it locally. So it's unavoidable to do a formal and proper evaluation of anything that we do around social prescribing in Singapore. And some of these questions about ethnicity and so on, we need to answer ourselves.
Thank you. So I'm going to condense the next question because I want to make sure that we can try to get to even one more question. So I think this one is for you, Dr. Chua, but Professor Goodwin, if you want to comment afterwards. So what sort of evidence is NUHS using to do social prescribing? And the questioner goes on to suggest, for instance, we could be co-designing and whether behavioral scientists are being used. So Dr. Chua, over to you.
Yeah, I have to say that it's probably more of a list of available resources that can be tapped upon. And I think our current strategy is really to connect the patients or the healthcare providers to be able to understand, the list of potential resources that are already available, and then to be able to recommend those to their patients. I think we haven't really gone the step, into looking into the evidence or providing new forms of activities that are, that are specially curated. But I'm sure that will come along the way.
Thank you. Professor Goodwin, any comment?
Yeah, so I think you have to be careful not to fall in the trap of needing all the evidence before you actually do something. So I think you have evidence-informed decisions to take forward, but in things like complex service innovations, you have to go through those cycles of innovation and learn as you go within the context in which you're doing things. So, I think as Professor Valderas suggested, you could take your RCT and therefore you planned everything out. But if you take it to the next neighborhood, it could fail miserably just because the context is different and the people are different. And that's true of all complex service innovations. So take some of that evidence that you've got, and I think you've already done that, and then test it out. The issue is what's the information that you're getting to see whether it's working, because that's going to tell you to improve things in real time. So small tests of change, regular feedback on experiences of people and experiences of professionals. And if you've got the data, you can really, over time, you can really run some good outcome data to see what's happening with your local population and your target. But if we don't do that, you're going to continually run blind, and all you've got is activity data and narratives. And that might be enough, but it's usually not enough if you want to release continued dollars to run something like this.
Okay, and now in the last minute, I'm going to combine a couple of questions. So do we need to design some new things to be able to do social prescribing? So do we need new metrics to measure effectiveness? Do we need new providers with new training? And do we need new shifts in responsibility to the community from the medical system? Dr. Chua, I'll turn to you first for 30 seconds, and then Dr. Goodwin for another 30 seconds, please.
Well, I think the quick answer is yes. I think we do need new resources, new training, a new vision, for social prescribing. And I think we need to align to all the providers to align together to that common vision, to do proper training. I think also in the areas of motivational interviewing, behavioral modification, and things like that. Yeah, so yes, I think we do need more resources into it.
Thank you. Professor Goodwin.
Yeah. I think it's yes and no. I think it's more of a shift in emphasis on what we do, rather than necessarily completely doing something different.